Good afternoon, everyone. This is my honor today to co-host this webinar with Dr. Shakir from Oklahoma University. We will be talking about simplifying stroke with a minimalist approach. So first, I will just start with a brief overview of current state of endovascular thrombectomy for stroke. These are my disclosures. If you look at the acute ischemic stroke in the past few decades, starting with NINDS IVTPA trial in 1995, it took the community over 2 decades to have first positive clinical trial for thrombectomy, which was a massive effort of advances in device technology, stroke system of care, patient triage, and stroke imaging. But since then, in every few years, we have had further expansion of indication for thrombectomy by utilizing advanced imaging and further pushing the limits of thrombectomy by really challenging the known concept of penumbra with a large core influx, and recently with RCTs on basilar artery occlusion. But this was a combination of really understanding of neuroimaging of patient selection and triage of stroke, and also the significant technological advances that we had for stroke in the past few decades, starting with early days. Now we have a new generation of large bore aspiration catheters, different classes of stent retrievers, guide catheters, and balloon guide catheter, which has collectively made stroke thrombectomy much safer, more effective, and beneficial for the patients. And at this stage of stroke thrombectomy with expanded indication for stroke patients, I think the focus is more now on expanding access to EVT, utilization of artificial intelligence, clot composition, and for the purpose of this talk, also optimizing thrombectomy system. And why do we need to have more, why it is more important than ever before to have more robust and optimized stroke thrombectomy platform. This is a work from our group is showing that like the number of thrombectomies being done in the country over the past 2 decades, as you see from 2015, has been significant increase in the number of thrombectomy nationwide. The reflection of that, which is the result of expanded indication, is like increased case volume from probably 1 case a week now, at least 1 or 2 cases a day, which and we also are doing more cases in older patients with comorbid condition. We're doing thrombectomy in more complex cases. Therefore, this really increases the chances of complication, potentials of burnout and fatigue, and the issues related to workflow of the team in terms of case turnover, the utilization of resources to handle the workflow of the daily endovascular suite. So therefore, more than ever, we really need to realize that how important it is to have ideal EVT platform which provide effective recanalization, safe navigation to target anatomy, and at the same time also simplified platform which is easy to prep and cost effective. This, if we go back to cornerstone of endovascular intervention, this has always been the access to target anatomy, which can provide support and stability. Historically, so-called tower of power, which has been usually a coaxial system of catheter, starting with a guide catheter, intermediate catheter, and a distal delivery catheter, which provide that support and stability that is required for a successful neurointervention, whether in a ischemic side or a hemorrhagic side. So that's how, until now, we used to use the system to own the anatomy with this tower of power. The entire tower of power is built in this new generation advanced guide catheter. As you see, the Zoom 88 support and Zoom RDL ranging in length from 100 to 110 centimeter are specifically designed to provide a stable and supportive access to target anatomy. This is just showing other features of Zoom aspiration system, including the bevel tip of the aspiration catheter, as you see in this video, maximizing the clot contact and facilitating the ingestion of clot into the aspiration catheter. So now in the following slides, I will try to further elaborate what I think the most ideal and optimized stroke system of care thrombectomy platform is in current state of thrombectomy. For me, for the large vessel occlusion stroke, the system includes the 8 French, the 45 centimeter destination sheets, Zoom 88 guide catheter with a selection catheter of either Simmons 2 or BTK over. This is important that to utilize 035 Advantage wire and Zoom 71 aspiration catheter. Most of the cases, as I will show you in the following slide, we probably don't need to have microcatheter and microwire to achieve a successful thrombectomy. We should have them available in the room in case needed, but probably most of the cases you're not going to need them. So this is a first example, case 1, 65-year-old gentleman presenting with right-sided hemiplegia, aphasia with NI stroke scale score of 14, left M1 occlusion. As you see here, the key in this approach is in your neck roadmap of AP lateral, you're showing all the way from aortic arch to the intracranial segment of internal carotid artery. So that will enable you to advance your 035 guide catheter all the way to cavernous segment, and then drive your guide Zoom 88 guide catheter to intracranial segment of ICA. And rest of the, as you see here, our guide catheter, 88 guide catheter, is in a petrous segment, and that will provide sufficient support to allow me to push my 71 catheter to M1 to achieve successful thrombectomy. TK3 with single pass, and my guide catheter is already on the skull base. Second case is 68-year-old a woman presenting with neglect and left-sided hemiplegia, disabled with an NI stroke scale of 18 with a right M1 occlusion. The same concept here again you see in my roadmap of neck run is showing all the way from arch to intracranial segment of ICA. You see the tip of 035 Advantage wire in a cavernous segment, and you can easily drive. The key is to spend 10 seconds, or in difficult cases, probably up to 2 minutes, to really advance your guide catheter to intracranial segment of ICA before starting to do your thrombectomy passes. So first, own the anatomy, use your tower of power to have a stable access to target anatomy, and then the rest of the case will be much easier. And as you see here, the guide catheter is in a petrous segment. I have the right M1 occlusion, and here you see that I'm able to push 071 Zoom 71 aspiration catheter to target anatomy without any microcatheter or microwire. And what makes Zoom 71 looks very effective here is just the support that it is getting from my guide catheter in the cavernous segment, as you see in these videos. and single pass TK3 for right M1 occlusion. There are also cases which are a little more difficult than the past two straightforward cases that I show. In this lady, a 85-year-old, presenting with left ICA terminus occlusion causing disabling deficit. We're taking patient for thrombectomy. As you see, the ICA has a full loop, 360-degree loop in the cervical segment. And again, the first goal is to own the anatomy, take the guide catheter to the skull base. In this case, because of the nature of the anatomy, I decided to have my guide catheter first into proximal ICA, and then I have 035 advantage wire inside 71 aspiration catheter, taking 035 to intracranial segment of ICA, and then driving 71 to cavernous segment, and then 88 would follow that. Again, to always have to take guide catheter to at least the skull base before attempting the first pass. And you see in this single shot, I'm sorry, that it's showing that the tip of 88 is in Petrus segment, and 71 is a little further up there, and the rest of the case is going to be very much easier because of the support being provided by my guide catheter and cavernous segment, and a large bore aspiration catheter will be easy to achieve full recanalization. Next case is a 62-year-old woman presenting with, as you see, a hyperdense left MCA sign here with an NI stroke scale of 18, and CTA is showing left ICA T occlusion. As you see on the left side, this patient had a very significant FMD. So I decided to first park my 008 Zoom 88 aspiration catheter in a proximal cervical ICA before this turn, and hope this video is played here. In this case, we decided to open a micro catheter and a micro wire to advance our aspiration, our guide catheter and aspiration catheter to intracranial segment. As you see in the middle of the screen, micro wire is a nice J going all the way up, and the O and Zoom 71 will follow that. And in the left side, you will see that 88 guide catheter will go over 71 to Petri cavernous segment. Again, spending extra minute to own the anatomy by accessing to the intracranial segment of ICA. Now we are ready to do our intracranial run, which confirmed the ICA-T occlusion. We did the first pass, just had a partial recanalization of the left ACA. As you see, the MCA is still out, but at this point, doing the next pass is very easy because my guide catheter is already in cavernous segment, so I don't need to worry about FMD and the difficult anatomy in the cervical ICA segment. So we were able to do the subsequent pass here and the TK2 recanalization. It's such a difficult anatomy. This patient I wanted to highlight here, just showing the current state of thrombectomy with a really streamlined system of care. Patient has symptom onset to ED arrival 49 minutes, ED arrival to CT scan even 11 minutes, and the growing access to recanalization 21 minutes in such a difficult anatomy with FMDs with only 2 passes with no complication, spasm or dissection. And the next day, this MRI is showing just a few hits here and there, an NI stroke scale of 0. Patient got discharged home within 48 hours. A little more difficult anatomy. This was the case that we had a balloon guide catheter that we were using. As you see, very challenging internal carotid artery. We decided to park this balloon guide catheter just above the ICA bifurcation, stable access, but lower than what we ideally want to have. So in this case, our support and access to anatomy is a little suboptimal. But as you see again here, Zoom 71 was able to be advanced over by the support which was received by balloon guide catheter up to the clot in the ICAT. We did the first pass, however, only opened the PCOM, and we still have complete occlusion of ACA and MCA. And as you see now, we have to do a second pass. The arrow is showing where my guide catheter is in just above bifurcation proximal cervical ICA in such a difficult anatomy. So we have to spend some time to re-access, essentially, to reach the target disease here. Spent some time, it was very difficult, so we had to switch to Zoom 88. And as you see in 5 minutes, Zoom 88 is in cavernous segment here in this tortuous anatomy. And this is just like the very classic example of stable access owning anatomy here. And we will see how important this is, because we did, after accessing with Zoom 88 and 71, we did the first pass. This is TK2B. However, as the arrow is showing here, there's a big clot and a very dominant M2 here, which can cause disabling deficits for the patient. So we have to do another pass. But the good news is I don't have to be worried about difficult cervical anatomy and high-risk vasculature downstairs, because my guide catheter is already in cavernous segment, and doing the next pass is going to be pretty quick and effective. And we were able to do this and achieve TK3 after 2 passes here. And the advantage here is in cases that you have to do intracranial stenting, or you need to do angioplasty, or you need to do centrifugal, that in all those scenarios, having the guide catheter, which is already an intracranial segment of ICL, will make all of those scenarios much safer and effective for the patient, and will improve the outcome. How about the posterior circulation? This was an 89-year-old gentleman presented with basilar artery occlusion causing disabling stroke with an I-stroke scale of 24. We did a radial access here with Zoom RDL. Extremely challenging anatomy. As you see, the size of the vessel is good, but with very tortuous anatomy, we had to spend some time. This is not the case that we can just push the catheter on its own. Probably we have to have a little more support here. That's why we open microcatheter and microwire to take our ADA to the vertebrobasilar junction. The ADA is in a V3, V4 segment of vertebral artery, and 71 is now pushed to the point of occlusion over the microwire and microcatheter, as you see here, and a TK3 recanalization achieved. And as you see on the left side, on the right side, this is just showing the follow-up run of the vertebral artery with no evidence of damage, dissection, spasm, or any untoward lesion, despite such a challenging anatomy. And again, in some scenarios, if you have to do subsequent passes in cases like this, having the large bore guide catheter all the way in the V4 segment will eliminate the need to cross this difficult anatomy for every pass if required. I think I will try to stop here, and Dr. Shakir will take over with his cases.
Beautiful cases, Shahram. It's always fun to watch that Zoom climb up. Let me share my screen here.
Thank you.
Can you guys see can you see my screen?
Yes.
All right. All right. Good afternoon, everybody. Thanks for joining us on this webinar. Glad everybody could make it. My name is Hakeem Shakir. I'm an assistant professor of neurosurgery at OU Health. And I'd like to kind of share my minimalist experience with Zoom and the Zoom system. These are my disclosures. So I want everyone to think about, every neurointerventionalist at 3 a.m. and what we want to do. We want to finish the case. We want to go home. And we want to go fast, like Ricky Bobby in Talladega Nights. And I think to enhance speed, we require tools and equipment that enable us to go fast. And truly, the Zoom system has kind of changed my practice and definitely made me faster when it comes to recan. So these are my kind of recipes from fellowship. If you can see those two columns here. Again, this is when I was in fellowship, so I'm kind of jealous of all the fellows on the call because you have access to the latest and greatest technology, which we did not have back then. We had, big, bulky, balloon guide catheters. We had Neuron Max at the time, which, was the heavily used catheter, but again, nothing that could get us up past the petrous segment into the cavernous segment, or even beyond the ophthalmic to do a thrombectomy, and with an 88 guide catheter. So the recipe has completely changed. And again, this is what we do, what we learn in fellowship. And I did this for a couple of years, and luckily Imperative came up with the Zoom 88, and again, really shifted how I approach acute ischemic stroke. I want to go through some slides here. This is a case demonstration of under 10 minutes. And this, again, you can see where the 88 is positioned. We did attain recan with the Zoom reperfusion system. And as some of you may know, and if you're up with the literature, the AO ADAPT paper came out with Dr. Grandi at Utah and this group, which talked about this kind of Aristotle only direct aspiration first technique. And in this study, thrombolysis and TICI-2B recan, a mean time to reperfusion of 16 minutes and a first pass recan of 66. Those are pretty good numbers, I would say. And if you look at their this table, the Zoom 71 was successful 15 out of the 19 cases, 79%, so more than any other aspiration catheter in the study. While this paper was being put together, I had already begun my transition to cutting out the microcatheter in the setup, and so that has that we'll touch on that here shortly. But I truly view the endovascular space as one that's constantly evolving, and I commented about the fellows having access to the latest and greatest, and it really is like the iPhone, right? Every year there's a new tool, new catheter that comes out that really kind of changes how we approach the pathologies that we take care of. And this is kind of how the Zoom 88 system and the Zoom system in totality has really changed my approach. These are some of the tools on the table we use now: balloon guide catheters, microcatheters, microwires, stent retrievers, and obviously aspiration devices. Dr. Majidi talked about, the advantages of the Zoom system, and you can see on this panel here how I'm able to climb and how we're able to climb up the 88, and in this situation, wireless. And there is a lot of advantages to having that bevel tip when we are reaching the clot interface. So I've witnessed this and experienced this firsthand. I'll be honest, I was a skeptic when the Zoom system first came out, but quickly became a believer after I was able to get the 88 beyond the cavernous segment. Here's a case demonstration of an M1 occlusion. So this is kind of my style right now. This is what I usually use. I use an Aristotle 024. I only open 3 or 4 things max, right? So I have a guide catheter, I have my aspiration catheter, and I have the wire, which in many cases is an Aristotle 024. And sometimes you don't even need the Aristotle 024, but it's kind of a mechanism for which, or a rail that I'm able to provide the 71 to get around and to the clot interface. And I want to show this again because you can see in this slide, the wire goes up and the 88, so the 71's getting pushed through, and you see the 88 buckling. That's okay, that's going to happen. When you're pushing on the Zoom 71, you're going to have a little bit of that force causing the 88 to kind of buckle down a little bit, but it's okay because you're able to get in this situation, and oftentimes, the 71 to the clot interface, and the 88 can climb up after that. So that's the recanalization. And Dr. Majidi touched on this as well, and I don't want to be redundant or superfluous here, but time to reload and reclimb matters because you're not always going to be successful with the first pass. We all know that. We're not trying to show you all first pass cases and telling you that this is going to work 100% of the time, because that's not true. But what we're trying to tell you is that if you have your 88 all the way up there, and in this case you can see it past Petrus, but if you have your 88 in such a good position to begin with, then reloading the few tools that you already have is going to be very easy. I remember as a fellow, the anxiety of having to, reload the system, especially as a junior fellow, not trying to get bubbles in your TUIs, not trying to, put the wire in, put the microcatheter in. If you go out in the community, you're relying upon a tech. So simplicity is key here. When you have less tools and less equipment to load up, it makes all the difference in the second pass or third pass if you have to. So again, another thing about the Zoom 88 is that it does very well in unfriendly and tortuous anatomy. And just to redemonstrate, you have kind of an FMD picture here and stenosis, but the 88 was able to climb up through this. So again, another recanalization with the reperfusion system here. So you can see how that 88 can get all the way up to the MCA. And what that does when you get your when you climb up and you utilize the equipment to its fullest potential, you can enhance the aspiration because you've essentially occluded the MCA and you blocked off the ACA. So you're not worried about backflow or any. I mean, once the 88's out in the MCA or close to the MCA, you're in pretty good shape when it comes to aspiration. This is the recan. It took 8 minutes from groin stick. And you can ask my staff if the case is going on longer than 30 minutes, we tend to get a little cranky. We get frustrated because we're spoiled now. We know that these cases should go and can go with the technology we have under 20 minutes. Another demonstration of, again, the technique that I've been utilizing, which has been very successful. Again, you can see I put a knuckle on the Aristotle 024 to kind of make this atraumatic knuckle, so I'm not just, poking right through a vessel and or clot. And you can see, again, the 71 goes to the clot interface, and I kind of give it a little bit more of a nudge there. And you can see the 88, it's backed out a little bit, but that's okay because now I've at least reached the clot. I'm going to apply aspiration, and then I will climb up my 88 thereafter. But these are only 3 pieces of equipment to get up there. So you can, again, similar to Dr. Majidi, you can see we have partial recan. There's an M2 branch that's still occluded. We need to go back. But my 88 is right there, ready to go, ready to reload. So second pass, you can see in this case here. So again, I think the emphasis I'm trying to make here, and I think we're going to hammer this home, is that it really does matter where you park your 88. If there's one thing you need to take away from this presentations, is that where your 88 goes can dictate the outcome and the success of your case. So now you can see a new recipe here. And this is kind of what I've been very pleased with, and actually got one of my partners to completely switch. You know, microcatheter is a thing of the past now, and I think that's where the field is going to push towards, is less equipment, more efficiency, less time on table. These are kind of the steps I wanted to hammer home here. You know, the key again, get your 88 as high as you can. And, you know, I'm asking, is that really how high you can get it? So if you're not if you're at the cavernous, okay, you're knocking on the door, you're kind of doing it right. And then, you know, the 71 over an 0.24 Aristotle for me. And again, you cannot be scared to apply a little bit of force to these catheters. They've been engineered so beautifully that you can apply, you know, force. Not only are they engineered to climb up, but they will tolerate a reasonable amount of force to get your aspiration catheter to the clot interface. So it's okay to apply some force to reach the clot interface. So last slide, I think, you know, with advancements in medical technology, it's going to revolutionize the industry, and ultimately we're here for, you know, patient outcomes and enhancing quality. So I want to thank everybody. I want to thank SNIS and Imperative for giving me this opportunity to brag on the 88 and the Zoom reperfusion system.
Thank you, Dr. Shakir. Yep, that's exactly the point. We had a patient 6 months ago came to us with a M1 occlusion. He used a system of choice, which is Zoom aspiration system. Thrombectomy successfully achieved TK3 in 12 minutes. But then our fellow was just doing some chart review. We found out that the patient had same M1 occlusion in 2011, over 10 years ago. We got very interested. We went into the case and see how they opened that LVO over a decade ago. So it was over a guide catheter and 041 aspiration catheter, and they had to push some IA thrombolytic, and they did few passes, and they were very skillful. They opened the occluded vessel for TK3 after 2 hours, and patient did so well. But the fact is, in today's technology, we don't really have to spend 2 hours to do the successful thrombectomy.
I know it makes me jealous, because I remember what it was like even in 2016 scrubbing a case. So yes, like I said, I'm jealous of the modern day neurointerventional fellows, but I didn't mean to interrupt. Go ahead.
And with current technology, it is really, we use the Zoom aspiration system to the best of its capacity, which really starts with accessing the anatomy, taking 88, as you mentioned, as high as you can safely go, which should be at least feature cavernous segment. The rest of the case is going to be very easy. I had a privilege of being trained by some of the legends here at Sinai, but it was, we did have cases that we had to go do direct carotid stick probably every few months. We did pretty well with that, but since the introduction of Zoom, it's extremely rare, at least in our institution, to encounter a case that you need to do direct carotid stick, because the catheter, the entire system has become so effective, so atraumatic, that those cases are become, probably you will see 1 or 2 a year, but those cases, no matter what you do, those patients are not going to do so well.
You know, the other thing that I wanted to touch on that I didn't talk about, because, you know, I wanted to show some of the cases, but, you know, we live in a cost conscious culture now. And as providers, You know, we are often measured not just by how your TICI was or how quickly your, you know, groin to reperfusion was, but, you know, you're also being measured and watched for how much product you spend on and how much product you're going through. And, you know, these hospitals often operate on razor thin margins. And the fact that we can do a case with less product means that the cost of the case goes down significantly, especially if you're able to achieve recanalization in quick time. And even if it takes a second pass, you're still saving cost immensely, because once that stent retriever is opened up, that's a significant added cost to the case. And it really has changed, again, my practice, because I used to open up a stent retriever almost routinely. Solumbra technique was just the way we did it. We thought it was going to work. We knew it was going to work. Open up the stent retriever. Let's have it ready. But now it's like, don't even think about opening that stent retriever until I fail, because we're so confident with the technology that we have now.
There is certainly a room and a space and need for stent retriever and balloon guide catheter for in thrombectomy space, but do we really need to use balloon guide catheter or stent retriever in every single case? I think the answer is big no. And if we are doing it and we are not using Zoom system, we are missing big time.
You know, and then the other thing I will say is that you know, we have to select out. So I don't know about you, but I want to make a very, you know, a strong comment about patient selection. If somebody's coming to you at the 22nd hour, you know, you need to have the mindset that aspiration may not necessarily be as effective as it would be within the 6-hour window, potentially on a softer clot. So there's a caveat to this minimalist technique, and kind of you have to be cognitive and you know, selective, I should say, about when you're going to use a technique, the right situation, right? And so if it's a fresh under 6 to 8 hour clot, this is the technique that I'm going to, you know, really push.
Great point.
I think we're supposed to open up to questions.
We had some questions if the audience wanna submit their questions. We had some questions being submitted before. I'm trying to open.
Yeah, somebody asked a question here. I'm trying to. How often are you able to use just a Zoom guide and a Zoom aspiration catheter and a wire in your cases? So again, like I think I just touched on that. It depends. Again, the age of the clot or the last known well is how I kind of game what product I'm going to pull. But as I touched on earlier, if it's before 8 hours or it's within 8 hours of last known well, I am going to use just a Zoom 88, a Zoom 71, and or 55, and an Aristotle 024, and that's what my staff opens. And they love it because they know this is kind of the 3 things we're going to need, right? There's no microcatheter, there's no triever, it's just very, you know, protocolized and very algorithmic for them, because, you know, staff rotates. We have a big center here, so, you know, it's kind of almost the same recipe. But I would say 60% plus of the time I would say that, and I think I'm being a little bit modest there.
Yeah. We also have another question here asking, how do you find Zoom catheter compared to Sophia catheter? I think Sophia catheters are great, and that's like great options for thrombectomy. However, with the introduction of larger bore aspiration catheter, I think the advantage that the Zoom is bringing is the larger ID, and it's, at the same time, the navigability is very comparable to Sophia. So therefore, if you can take 71 catheter to M1, so you rather just go with a larger aspiration catheter compared to Sophia, which comes 6 French or 5 French.
All right. Okay. There is a question about the experience and setup with Zoom Radial. So Dr. Majidi, you showed that one radial case. I'll let you take that one.
Well, my position for radial access for stroke is only for posterior circulation, or if there's a specific reason to apply that for anterior circulation, because I still think femoral access is faster and more effective. It's actually the same mindset that you want to in and out in 10 minutes for anterior circulation. Femoral works for that, but the Zoom 88 and Zoom RDL, both for radial access for posterior circulation, has been very effective. I prefer to use a short 8 French sheath, but you also have an option to go sheathless because Zoom RDL comes with an introducer. In a hemorrhagic space, I routinely prefer to use a radial access for aneurysm or AVM embo, and Zoom RDL and Zoom support has been extremely effective in taking the guide catheter through intracranial portion of ICA. Another question here.
So I will say this, the thing is about radial, your staff has to be comfortable and eager and ready to do those kinds of things. So for me, it is a function of it's a function of the staff willing to put that together for me at 3 a.m. So at 3 a.m., my mindset is I want to go groin and I want to go home, because the radial is oftentimes, like Dr. Majidi said, kind of a bailout if I have to, and for posterior circulation. So radial is not my setup. I am a radialist. I'm a big time radial guy, but for thrombectomies, I want to be in and out. And I think with radial, it's not, in my hands, in my experience, as effective with compared to the femoral approach.
Another question: how often you're able to take push Zoom 71 to the clot without wire, microwire, or microcatheter? And again, as I mentioned, in M1 occlusion, ICAT occlusion, I don't open microcatheter, microwire. 6 or 7 out of 10, you are able to clot and do thrombectomy without the need for those devices to be open. There are obviously difficult cases, 1 or 2, that you have to open microcatheter or even utilize stent retriever for a successful thrombectomy.
All right. One of the questions is, how many dissections have you had using the Zoom 88? I'll be honest, I haven't had any significant flow limiting dissection or any dissection I can remember, and much, I think about the days of Neuron Max. So the 88 is actually very friendly and forgiving. I mean, and I'm one of those guys who really pushes the catheter. I hate to say that I'm a pusher, but I really push that 88, and so been very blessed and lucky. I honestly have not seen significant dissections with the 88.
I completely agree. It is extremely hard to cause dissection with Zoom 88 or TrackStar or Zoom support. Sometimes in hemorrhagic cases, we might see some mild spasm, but dissection I haven't encountered either. The next question is, when you're taking 88 high in intracranial section, are you worried about flow arrest or flow limitation? Shakir, you want to take?
Yeah, so in many cases that 88 provides, either occlusiveness or subocclusiveness, which can enhance, I think, the aspiration quality. So first of all, crossing a cervical kink and redundancy, it does it beautifully. I've seen it where the kink can be straightened, or it just swims around the loop, as Dr. Majidi showed. But even if it's subocclusive, that may offer an advantage when you're trying to directly aspirate on the clot. Right now, you have in some ways flow arrest. So I think there's an advantage to that. So I don't look at it as a problem. How about you, Shahram?
Completely agree, especially when it is in a supraclinoid segment. It becomes partially occlusive, but that is great. The risk of having a secondary distal emboli will be minimized. You basically have a functional balloon guide catheter up in the intracranial segment.
Okay, next question is, have you used any of the new delivery catheters such as the Tenzing or Sendit?
Yes, they're both great new advances, and it is good to have this the new tools. Those catheters are delivery catheter are very helpful when you're in trouble crossing over ophthalmic, and it will really facilitate and speed up the procedure. However, when you're using Zoom system, the support that you're getting from Zoom 88, right, just below ophthalmic, really minimizes the chance of getting stuck in ophthalmic artery. So they're really, when you really maximizing the things that you can do with Zoom, you probably don't need a delivery catheter with it most of the time. Sometimes I even put a 035 advantage wire all the way to cavernous segment, and pushing 88 will really help 71 to cross ophthalmic and go to the clot.